Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article entitled First Signal, First-Line Single-Agent ERISA versus Gemcitabine and Cisplatin in Never Smokers with Adenocarcinoma of the Lung by Ji-Young Han et al. My name is Paul A. Bunn Jr., MD. I am the James Dudley Endowed Professor of Lung Cancer Research at the University of Colorado Cancer Center in Colorado. I am also the Executive Director of the International Association for the Study of Lung Cancer. I am a board-certified medical oncologist specializing in thoracic oncology. Platinum-based doublet chemotherapy has been the backbone of first-line therapy for patients with stage 4 non-small cell lung cancer since large randomized trials and meta-analyses of these trials showed that such therapy prolonged progression-free and overall survival. However, there are many limitations to this cytotoxic chemotherapy approach, including the fact that 1, it is indicated only in patients with performance status 0 or 1. 2, it is associated with relatively low response rates, about 30%, and there are no ways to select patients more likely to benefit. 3, grade 3 and 4 toxicities are common. And 4, the intravenous administration of the drugs is required once or twice every 3 weeks. The epidermal growth factor receptor signal pathway is required for renewal of all epithelial tissues, including the bronchial epithelium. In the normal bronchial epithelium, EGFR is expressed in the basal layer, and its function is tightly regulated by activation and deactivation in response to local growth factors such as EGF, TGF-alpha, and amphiregulin. EGFR expression is increased in dysplastic respiratory epithelium and in the majority of non-small cell lung cancers. Thus, it provides a rational target for new drug development. Oral tyrosine kinase inhibitors such as gefitinib and erlotinib were shown to produce objective responses in a small minority, about 10% of unselected lung cancer patients who have progressed on standard chemotherapy. Analyses of the EGFR gene in responding patients showed that most had activating mutations in the EGFR gene, and these were localized to deletions in exon 19 or point mutations in exon 21. These activating mutations alter the structure of the tyrosine kinase domain of the receptor in a manner similar to ligand binding, thereby constitutively activating the receptor even in the absence of ligand. These activating EGFR mutations were more frequent in certain clinical and histologic patients, including those with adenocarcinoma histology, light or never smoking status, female gender, and Asian ethnicity. These same clinical features were associated with a higher response to EGFR tyrosine kinase inhibitors. These observations made it logical to compare single-agent oral EGFR TKIs to intravenous chemotherapy in the first-line setting in patients with activating EGFR mutations, or in patients likely to harbor such mutations. First Signal was one of 6 large Phase 3 randomized trials addressing this issue. The First Signal trial was conducted in Korea and randomized untreated, advanced, never smoking adenocarcinoma patients to receive gefitinib or combination chemotherapy with gemcitabine and cisplatin. Molecular testing was not required for entry, but was requested on as many patients as possible. Response, progression-free survival, and overall survival analyses were planned for all patients and for those with and without activating EGFR mutations. Progression-free survival in the entire cohort was the primary endpoint. First signal results in patients with activating EGFR mutations showed a response rate of 85% in those treated with gefitinib versus 38% in those treated with gemcitabine and cisplatin. The median progression-free survival in the EGFR mutated patients also highly favored gefitinib, 8 months for gefitinib versus 2.1 months for chemotherapy. Overall survival only slightly favored gefitinib, 27.2 versus 25.6 months, and these differences were not statistically significant, but were likely to the crossover effect of mutated patients receiving second-line gefitinib. Progression-free survival at 1 year was 16.7% in the gefitinib arm and 2.8% in the gemcitabine cisplatin arm. Results of this trial were similar to the other 5 trials addressing the same question. In these 6 trials combined, the objective response rate was 57% in mutated patients receiving an EGFR TKI, but only 33% in the chemotherapy arms. Similarly, progression-free survival was longer on the EGFR TKI arm of all trials in mutated patients, with an average of 10 months median progression-free survival versus 5 months, essentially double. The overall survival result favored EGFR TKI in the trials, but was not significant in any. Median survival was 26.1 months in TKI arms and 23 months in chemotherapy arms. These survival analyses, however, were complicated by the crossover to the alternative arm, which happened in the majority of patients. Patient-reported outcomes, including symptom benefit and quality of life, were reported in only 2 of these studies, including first signal. In the IPASS study, symptom improvement and quality of life were superior in the gefitinib arm in patients with an EGFR mutation, but were superior in the chemotherapy arm in patients without an EGFR mutation. In first signal, patient-reported outcomes were poorly collected, and there were no significant differences between the arms. These data can be compared to the results of tamoxifen and other SERMs in the treatment of ER and PR-positive breast cancer. Tamoxifen therapy is preferred first-line therapy for those with ER-PR-positive disease because it has higher response, longer progression-free survival, better quality of life, less toxicity, and is more easy to administer. Survival is not improved, whether the hormone therapy is given first or second. However, first-line therapy is preferred with tamoxifen or SERMs because of the better response rate, progression-free survival, quality of life, toxicity, and ease of administration. Now in advanced lung cancer, the paradigm is similar. For those with an activating EGFR mutation, first-line oral EGFR TKI therapy is the preferred approach. And this, of course, implies that the molecular testing must be done before instituting therapy. We must remember that IPASS and first signals were designed to select patients on clinical and histologic grounds, not molecular features. With clinical feature selection alone, there were no significant differences in any efficacy endpoint in either trial. What happened to the patients with EGFR wild-type tumors? In both studies, there was a higher response rate, longer PFS in the chemotherapy arm. And in IPASS, the patient-reported outcomes were better in the chemotherapy arm and those with wild-type EGFR. Although overall survival was not significantly different, again due to crossover, it favored the chemotherapy in the non-mutated arms of the trials. These results provide additional evidence for the importance of molecular testing prior to institution of therapy. Patients with EGFR wild-type tumors have a better outcome on initial chemotherapy. Thus, there is a new paradigm for the management of advanced lung adenocarcinoma, and that is to perform molecular analysis to choose initial therapy based on the molecular results. The recent approval of crizotinib in patients with EML4 ALK fusion gene activation of ALK confirms these results and adds a second molecular analysis that once again needs to be performed before instituting therapy. This concludes this JCO podcast. Thank you very much for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.